Hi guys, let's continue pathophysiology of hyponatremia. Okay, so pathophysiology also is divided according to the this three groups that I told you earlier: hypovolemic hyponatremia, hypervolemic hyponatremia, and euvolemic. Okay, but it is almost the same. As I said, that it is mostly caused by increase in AVP, arginine vasopressin. You remember this arginine vasopressin? Okay. Let me tell you a brief introduction about arginine vasopressin. There is a hypothalamus which synthesizes this hormone. This, first of all, this hormone is also known as antidiuretic hormone, arginine vasopressin or argipressin. Okay, so it prevent diuresis. Okay, so it is synthesized in hypothalamus, it is stored in posterior pituitary, and from there it is released, okay, in some situations. So what it does is it has two functions. It will reabsorb the water. Okay, it will reabsorb extra water and from the renal tubule. Okay, and maintain the normal fluid level. And second function is it constricts the arterioles and increase peripheral resistance, and thus maintains BP. Okay, so these two are important functions of arginine vasopressin or argipressin. Okay, so this is most important in hyponatremia. Okay, because it is increased. Hyponatremia occurs as a result of increase in AVP. Okay, so hypovolemic hyponatremia, if there is hypovolemia, like take an example of diarrhea or vomiting, there is a much volume loss. Okay, so it activates neurohumoral mechanism, okay, which in turn stimulates renin angiotensin aldosterone axis, that is RAA axis, sympathetic nervous system, and AVP. So this increase in AVP or increased sensitivity of AVP, which leads to the increased retention of ingested free H2O. If H2O thus retained, then it causes hyponatremia. How it does that? Because if H2O is increased, the volume, the this fluid volume is more as compared to solute in the vessels, so it's gonna dilute now. So that's why there is hyponatremia. Hypervolemic pathophysiology is similar to hypo. Okay, then euvolemic, as I said, there is SiADH. Okay, so there is this pathophysiology works. Now there is a term, there is also one type, that is acute symptomatic hyponatremia. Apart from the three groups that I discussed, there is one another type, that is acute symptomatic hyponatremia. It is a medical emergency. Okay, and it is most common in women, mainly premenopausal women, and it affects more women than men. Okay, it occurs because of some iatrogenic causes like post-op period, thiazide, diuretic, colonoscopic preparation, etc. Okay, so what happens here is, in acute symptomatic hyponatremia, there is a sudden drop of this serum sodium level, which overwhelm the capacity of brain to regulate cell volume, and which leads to cerebral edema, seizures, and death ultimately. Okay, so next is diagnosis and investigations. So what are the investigations? First, we need to rule out pseudo-hyponatremia. Pseudo-hyponatremia occurs because of the hyperproteinemia or hyperlipidemia. Okay, because of these two reasons, pseudo-hyponatremia occurs. Why this happens? If you consider hyperalbuminemia, okay, in hyperalbuminemia, the more there is more albumin in blood. Okay, so it will it's gonna filtrate from the this our tubules. Okay, there is increase in GFR. Okay, so it won't allow water and other things to filter. Okay, then if this happens, then there is less hyponatremia is there. Okay, there is less sodium that get reabsorbed from the tubules as a result of. So if less sodium and water is absorbed, then there is less sodium and water is reabsorbed. Okay, so that is pseudo hyponatremia, because it occurs because of the hyperproteinemia or hyperlipidemia. Okay, so first we need to rule out this. Then there is serum glucose. In serum glucose, we need why we need to see serum glucose, because every 100 mg per deciliter rise of glucose will lead to 1.4 millimoles fall of sodium. Okay, so we need to evaluate serum glucose, then serum sodium obviously, then BUN, that is blood urea nitrogen. These may be increased because of some renal causes. Then hyperkalemia is there. Urine electrolytes and osmolarity is also important. Then what about treatment? There are mainly three considerations in treatment. First, we need to consider the symptoms. If symptoms are present, absent, or severe. Then next is chronic. In chronic, we can say hyponatremia is chronic if it is present from more than 48 hours. Okay, so we need to consider this thing if it is chronic one. And lastly, the response to treatment. Okay, how patient is responding. If we Because if we give hypertonic saline or some vasopressin antagonist, then we need to monitor this serum sodium level every 2 to 4 hourly, because the effects of these things are unpredictable. Okay, so that's why these three considerations are very important in the treatment. So first, treatment also according to these three types. Okay, so in hypovolemic, as there is volume is less, we need to administer it. Simple volume administration. Isotonic crystalloid is administered, and it is mainly choice of fluid is 0.9% NaCl, that is normal saline. Then hypervolemic, as I discussed the causes, it is mainly due to some cardiac diseases like cardiac failure or cirrhosis or nephrotic syndrome. So we need to treat the underlying disorder. Okay, so afterload reduction in cardiac failure, then IV administration of albumin in this thing, cirrhosis, and immunomodulatory therapy in nephrotic syndrome. Then sodium restriction is important here. Okay, hypervolemia, sodium restriction, this one is odd, because we think that in hyponatremia we need to we need to give sodium, but here we need to restrict sodium. Okay, because of hypervolemia. Diuretic therapy is important as there is edema. Diuresis is important. Okay, diuretics should be given. Vasopressin antagonist, that is anti-diuretic antagonist, that means ultimately diuresis. We should promote diuresis. Okay, that is why tolvaptan or conivaptan. Then H2O restriction in some patients. Then euvolemic, treatment of underlying disorder, SIADH syndrome, remember. Okay, so here treat this syndrome, and H2O restriction less than 1 liter per day is advised, but it proves ineffective nowadays. Then vasopressin antagonist is the main treatment here, because we need to maintain the this levels of vasopressin. Okay, that is SIDH syndrome is the main cause now, that's why vasopressin antagonist. Then loop diuretics with oral salt tablets and palatable form of oral urea. Okay, so these are euvolemic. In acute symptomatic hyponatremia, the only treatment is hypertonic saline. Okay, so I hope you got something. If you have any doubts, you can let me know in the comment section. Thank you.